Our next speaker will be Dr. Georgina Peacock, who is Director for the Division of Human Development and Disability at the National Center on Birth Defects and Developmental Disabilities at the Centers for Disease Control and Prevention. Dr. Peacock is dedicated to the health and development of children and adults across the lifespan and has applied her personal passion and knowledge to a critical leadership position at the CDC. In her role at DHDD, Dr. Peacock directs CDC's public health approach, which helps children and adults with disabilities get the most out of life by supporting programs, surveillance, research, and policies that facilitate better health care, increases in accessibility and inclusion. DHDD also works to optimize child development for those at risk for high-impact conditions so children can reach their full potential in life. Dr. Peacock oversees a division staff focused on the best health outcomes for populations that you can see in your full bios there. As if her responsibility at CDC weren't enough, Dr. Peacock continues to see patients in multiple clinics. Dr. Peacock, thank you so much for taking your time to come and spend with us and speak to us about ADHD and a host of other issues.
Thank you for having me here today. And I was just reflecting as I was hearing the first two speakers, where a lot of those children who get expelled from preschools, one of the last-ditch efforts that happens is they send them to see a developmental pediatrician, or they send them to see, and they say, maybe you can try medication, maybe you can do something to change the behavior that we're seeing in the classroom, not thinking about the behavioral approaches that Dr. Gilliam talked about, but thinking about that quick fix. And so I'm going to talk a little bit about the work that we are doing related to child development, the work that we're doing related to children's mental health, and then also in specifically attention deficit hyperactivity disorder. It is interesting to think that the work we're doing here, we need all of these different types of professionals thinking about this issue. When I was seeing children in clinic more regularly, by and large, there were many more boys than girls, and I think it's reflected in the first two speakers that we've heard, why they're ending up in pediatricians' offices, and then pediatricians are trying to figure out what to do to both serve the families, keep children in school, and do what is right. And hopefully the work we're doing at the CDC, as well as the work that the other speakers are doing, are really focusing on helping to help boys and help children be successful. Okay, so I can just speak first. I'm at the National Center on Birth Defects and Developmental Disabilities, and we have a range of public health programs that include saving babies through birth defects prevention, protecting people with blood disorders, and improving health for people with disabilities, and then finally, where I'm going to focus today, helping children by understanding developmental disabilities and those at risk for disability and delay. So we can go to the third slide, where I'm going to talk a little bit about our work in child development. As we've heard, the early years in a child's life are very important for ultimate success and reaching full potential in life. And while children progress at their own rate, we do know that there are typical developmental milestones and places where children will make progress, and we know what those developmental milestones are. So one of the programs in my sister division is the Learn the Signs Act Early program, which is a program that talks about developmental milestones that children should meet, and then gives parents, healthcare providers, and early educators resources to know what to do if there's a red flag, if a child isn't reaching the milestone that they expect. We know that physicians, that pediatricians, that family practitioners are doing developmental monitoring and then developmental screening in their clinics, and this is also being done in early childhood programs. The goal for this is to find children that are exhibiting differences in their development, differences in their behavior, so that we can intervene early. What we're talking about is setting these children forward on a path of success, and we need to do this by identifying early and thinking about ways we can intervene early. In addition to focusing on development, we also look at children's mental health. We know that for children to be healthy, they need to reach not only developmental milestones when we expect, but emotional milestones, and develops healthy social skills. When this isn't happening, people start to talk about childhood mental disorders or mental health disorders. And a childhood mental health disorder is something that starts in childhood. And these children have serious challenges being successful in the places where they learn and play. So that's when we're talking about conditions such as attention deficit hyperactivity disorder, mood and anxiety disorders, substance use disorders, Tourette's syndrome, different kinds of mental health disorders. And I think the important thing to think about is while a subset of this population that we may be talking about may have a condition like attention deficit hyperactivity disorder, those children and children that are exhibiting disruptive behaviors for other reasons all will benefit from early intervention. Some of those early intervention programs are protective or preventative in nature. So they're focused on positive parenting. They're focused on teaching parents, giving parents skills so that they can work with their children in positive ways that will help children develop those skills. These are the same types of skills that we would like early childhood providers also to be learning so that they're having positive interactions with the children in their preschools. In the preschool settings. And then there are programs also, or there's interventions there to look at behavior therapy for children that have these disorders. And behavioral therapy is something that is really parent training. It's really teaching parents to understand their children and figure out how to develop those successful skills. CDC's role in ADHD has a number of different approaches. So the first thing that we do, and I think CDC is known for doing this, is we track the number of children who've been diagnosed with ADHD. When there's some nuance to the words I'm talking about, we're tracking the number of children diagnosed with ADHD by parent report. So the National Survey of Children's Health asks parents, has your child ever been diagnosed with ADHD? And those are the surveys that we're using. Not only do we have those, we also conduct some public health research. And the project to learn about youth or play mental health is a community-based project that's looking at causes, it's looking at risk factors, and it's looking at outcomes of childhood mental disorders. This including ADHD. Some of these community-based programs are in Florida, in Ohio, and in Colorado. And then what we do is we use this data, we use this information to help inform clinical and state practices. And I will talk a little bit more about one of the initiatives that we have going on at the CDC today. We also do health and education and outreach and partner with the National Resource Center. We have some representatives here in the audience today to help provide resources for families, for providers, to help understand attention deficit hyperactivity disorder. And then, of course, we collaborate with partners. We work with family organizations, we work with professional organizations to help improve health outcomes for children with attention deficit hyperactivity disorder. So ADHD is the most prevalent mental disorder in childhood, and about 11% of children aged 4 to 17 have ever been diagnosed with ADHD. And about 1 in 3 of these children were diagnosed before the age of 6. We know that ADHD is a neurodevelopmental disorder that's lifelong, and we see symptoms of inattention, of hyperactivity, and impulsivity. And we also see that there are troubles not only in one setting, but in home or in school, or home and a child care setting. So you do see impairments in multiple settings, and the onset occurs before age 12. We know that a child who's been diagnosed with ADHD has a higher childhood and adolescent rates of peer problems, of academic failure, of injuries, and also that in adulthood we'll have challenges with employment, incarceration, and family disturbance. And we heard a lot about the costs related to some of the challenges, and if we think about ADHD and people that have been diagnosed with ADHD, looking at indirect and direct costs, the amount is staggering. As you'll see here, an estimation of $72 billion per year. In thinking about differences between boys and girls, and again, this information comes from the National Survey of Children's Health, we see not only that boys are diagnosed at a higher rate with ADHD than girls, but you'll see that all of these different disorders and all of these different conditions are seen at higher percentages or higher rates than girls. And we also, though not shown on this slide, see developmental delay and intellectual disability at a higher rate in boys than girls. I'm rushing through these slides just a little bit because I want to make sure our other speakers are able to speak as well. But I'm happy to provide more information afterwards if that's needed. We heard a lot about genetic differences between boys and girls, and I would urge you, as Mr. Gurian has talked about, look at those differences in the brain scans between boys and girls. There are significant differences. There's also significant differences between a person with ADHD and a person without ADHD. And even if you look at children diagnosed with ADHD, you'll see differences between boys and girls' brains when they have ADHD. So I think coming to that core root and understanding that there's a lot in neurobehavior that tells us about these differences that we're seeing. The other thing that we see is that boys with ADHD tend to have either more severe symptoms or they have more noticeable symptoms. They may have more hyperactivity, they may have more impulsivity, more aggression, and more inattention. So you're seeing a difference in symptom expression that impacts the way they are viewed by the professionals that work with them, by the teachers, by the peers, and those differences can contribute to lower self-esteem. They can contribute to peer problems, school problems, because of this difference that we're seeing in the way we see symptoms of ADHD in boys compared to girls. So now I'm going to turn to an initiative that we're working on at CDC right now, which really, I think, highlights a lot of the issues we heard about that are related to the early childhood period. We know that about 200,000 children have been diagnosed with ADHD that are aged 2 to 5. That's really young. The fact that a 2-year-old is being diagnosed with ADHD, when we say that reliably we're not, you usually can make a diagnosis at about the age of 4. But in these surveys, parents are telling us, my 2-year-old has been diagnosed with ADHD. So we know, as we've heard, that children with disruptive behaviors are more likely to have trouble in childcare, in school, to be expelled. And we also know that children with disruptive behavior, there's a significant amount of parental stress. There's a significant amount of issues related to parent and child relationships. The American Academy of Pediatrics recommends that children diagnosed with ADHD receive behavioral therapy first and medication as a second-line intervention. What that means is behavioral therapy is really parent training. It's teaching parents to encourage positive behaviors and discourage negative behaviors. It's providing structure and support, and it's improving relationships with family members and peers. And so this initiative that we are working on is trying to get professionals to align their clinical practice with best practice, which is behavioral therapy first for these youngest children diagnosed with ADHD. And why does this matter? Because when we look at 4 to 5-year-olds medicated for ADHD, this number has doubled in 4 years. We also know that children diagnosed with ADHD, only 50% of those preschoolers have had any kind of behavioral therapy. So any kind of interaction where their parent is learning how to deal with positive behaviors in their children and set them on a route for success. So while there may be some individual cases where medication may be the right answer, it certainly is not the first answer. The first answer is creating these situations where both families and child care providers and all those others who touch young children understand how to create an environment for success for children. You'll see in your packets that we have some state-level profiles. We included a few different states, or they may have been out on the table. We have these state profiles where you can look at the medication rates and the behavioral therapy rates in the different states based on this National Survey on Children's Health data. At the end, you'll see a resource where you can find the specific information about your state. So I think with that, I'm going to turn to my other speakers and give them a chance, because I really want to hear what you all have to say. But thank you for your attention. I'm going to move you to the last slide, which just shows you some different resources that we have, the work that we're doing on ADHD, those profiles, links to those profiles I talked to you about, some recent publications, and information to our National Resource Center on ADHD. And thank you for your attention, and I will turn it over to you. Thank you.